Primary, secondary. A lot of times it's that age group that is a daredevil-ish, 15 to 24-year-olds, the ones that it says no diving in a pool, and they do it anyway, especially like on vacations and things like that because they think they're above that. And then they come in and they have brain injuries. The problem with brain injuries, if we think about this, your brain is enclosed in this skull, right? The skull doesn't budge. However, it's not necessarily a primary injury that does the damage, it's a secondary injury. It's the swelling and the injury that comes after the initial injury that is the problem. And that's where the bigger problem lies. So just in general with brain injuries as a whole. A couple of things, scalp wounds, we know that the head or head area, the scalp, facial, is very heavily bleeding, blood, lots of blood, a lot of vascular. If you think about it, there's not a lot of adipose tissue to absorb any of that blood, right? And so it's got to come out because it's got nowhere else to go. So that's one of the reasons why. Skull fractures, two big fracture base of the skull, two signs that are associated with it. The battle sign is ecchymosis right behind the ear. So that is one sign of a skull fracture. And then you have the halo sign, which when you take a piece of gauze and you see dripping, you'll get that ring of fluid around the blood stain. And that's your CFS leaking. So it's very pronounced, and just what that definition is, that's exactly what it looks like with a skull fracture. So, clinical manifestations or signs and symptoms, pupil abnormalities. You know, we don't have that perfect world of our perla. And then we have of course, the alters in LOC, changes in vital signs, headaches, seizures, all of that can also play a role in our clinical manifestations of head injuries. So just to name a few head injuries that we're going to go through. Closed brain injury, blunt traumas, the acceleration, deceleration injury. So it's that coup de coup idea where it goes to front to back and then back to front. Open is anything that penetrates through. One thing about open, of course, we worry about infection, right? And so that's the biggest thing. At least it has a little bit of space to swell, but we don't want it to herniate out, right? Because we don't want that brain to get exposed to anything else, even though it's already open. Concussion is that temporary loss of consciousness. You know, the old wise tale used to be that when there's suspicion of concussion, you know, you don't want your child to go to sleep, stay up for hours, you know, talking to them. And the reason why that is, if you think about it, it wasn't so much the concussion, right? It's that whole primary, secondary. It's the whole idea of the secondary injury that could come with the swelling. So they would have a change in LOC. So it actually it's a wise tale, right? But it also holds true because we don't want that brain to stop, you know, to swell. We're not going to keep them up for hours because you hear a lot of stories of, oh, mommy, let me go to sleep, and no, you can't, and so you're, you know, a lot of moms or grandmas or grandpas or whatever were up with the kids for a long time because they were worried about that. So if there's a change in LOC, right, we just talked about earlier, and then that projectile vomiting, right, because that's something they're going to see. So that's what you would encourage them to assess. So again, it's a secondary injury that's the problem when it comes to that. Contusions, that bruise, major injury, and then again, checking for that eye intracranial pressure as a whole. Brain injuries, just some other ones that we're going to go through here in a bit, and then concussion. So report immediately, look for that headache, nausea that comes along with the vomiting, the dizziness can also be reported, encouraging them to keep an eye on that as well. So, leading into the hematomas, here is just a visual. Again, blood on the brain is not good. So, they're all bad in general. We have the epidural hematoma, you'll see where it's at, subdural hematoma, and then you have the intracerebral hematoma. So it just gives you a visual of where they're located. And you see what happens to the brain tissue itself in those pictures as well. So, epidural hematomas, emergency situation, LOC, can't stress it enough. We need to check the LOC. Treatment measurements, maybe it's in need of a burr hole, They actually drill into the brain, burrow hole it, just like the little bunnies do in their yard to make a nest. Same kind of concept, and to relieve and get that hematoma removed. And then they could actually open up the skull and remove it the same way. That's where your craniotomy comes in. So it's either something a little bit less, still invasive, but less invasive, is a burrow hole, or a craniotomy would be much bigger. The idea, of course, is to reduce that ICP and then monitor respiratory support, all of which needs to be handled with all of these patients. Subdermal hematomas, collection of blood between the dura and the brain as a whole. Acute, subacute, or some patients suffer from chronic. Treatment varies on the size of the clot and how they can remove that clot. So it's the size and how they can remove it. The intracerebral hemorrhage, it occurs in the brain itself. Supportive measures, controlled ICP, craniotomy, and removing that clot, they will get it opened and removed that way. But all of which then talks about any of the symptoms later, any injury, swelling, all of that we need to support total care of that patient again. Diagnostic evaluations for these patients listed there. Then management of a patient with a head injury in general. A lot of times with head injuries, we also have to have support of that C-spine. No brainstem, no control of that C-spine, no vital signs. That brainstem is what focuses on our vital signs. If there's a disruption in that brainstem itself, then we're thinking our vital signs of our patient. So that C-spine has to protect it. Collared, C-collar and a backboard. Until that C-spine is ruled out okay, then we can take them off and remove once they have been cleared that their C-spine is okay. Again, no brainstem, no patient. When it comes to also supporting, we have the respiratory support, looking back on that ventilator scenario with the program controls, I couldn't think of the word, controls of that airway support with that ventilator, all of which you see listed here. Can't get any clearer than that. Again, nasogastric tube or NG tube is for that decompression, for that for that airway support to help with that respirations and get rid of that air in the stomach. Assessment in brain injuries as a whole, going back to the whole scenario. LOC, Glasgow Coma scales, rating them from that 3 to 15. Complications, I think, are all very much self-explanatory. Ongoing assessment, monitoring the vital signs. Again, suctioning with caution with these patients. Yes, you need to maintain that airway. However, you don't want to cause their intracranial pressure to go up. Here, a little bit different, interesting side note. The patient is on supportive airway or respiratory support with a ventilator. We said earlier that the patient has to have soft wrist restraints on, right? These patients are probably less likely to have sedation, but we have to keep, again, that ongoing frequent assessment to make sure that they're not coming fully alert, okay? Because if they do, they're initially going to want to, one, extubate themselves. So that's why it's ongoing frequent assessment. If they do have any sense of coming to where they have restraints on, that being restraint is going to cause their ICP to increase. So that is why it's contraindicated to use soft wrist restraints in patients with brain injuries as a whole. The stress will increase the intracranial pressure, so keep that in mind. Avoiding shivering, just going back and reviewing what we said earlier. Whether it's too cold or too hot for the patient, we have to control the shivering. Patients with fevers, you give antipyretics. If it's because they're cold, then you give them warming, something warming. Warming blankets, but you warm them up to avoid, to help with that hemostasis and controlling that temperature. Family teaching, cognitive support with the family too, explaining what they're gonna see. If they wanna see the patient and you've already communicated with them. Again, communication with them is the key as well. Spinal cord injuries. Spinal cord injuries still the daredevil kids age of, they even say it's greater with spinal cord injuries. Those that are older, 16 to 30, is kind of the key. Adolescents, males are more likely to cause injury, more at risk for spinal cord injuries. It is the same thing like it is with brain injuries. It's not the primary injury, it's the secondary because of the swelling. Within 8 hours of a spinal cord injury, what is one of the best drugs we can give them? Methylprednisolone, Solumedrol. And that's going to be given every 8 hours to help that swelling in that spinal cord. To decrease that inflammation, because again, it's that whole idea of that secondary injury could potentially be more fatal for the spinal cord as a whole. It's that whole swelling idea. So treatment is going to be determined on what happened with that injury, and then that goes into our spinal shock. They lose reflexes. Keep in mind, at the point of injury, anything below the point of injury in the spinal cord, they are not able to perspire. So if no matter where it is in that spinal cord, anything lower than that injury, the patient will not be able to adapt their skin to perspire. So this is not a patient who should be sitting in the sun, right? Because they cannot cool themselves off, whether it's the sun or a heated room or anything like that. Because from the point of injury below that, they cannot regulate. Okay? So you have to use caution with these patients when it comes to that. That body part does not, below that, does not perspire. Neurogenic shock goes along with that as well. Pulling peripheral vasodilation. So you might see swelling as a whole for that vasodilation. One thing that I didn't mention that I'm going to now, what drug is the drug of choice for cerebral edema? Mannitol. What kind of drug is that? You sure? Osmotic diuretic, mannitol. Mannitol needs to be given within fairly quickly of a cerebral or brain injury. They use the corticosteroids for spinal cords, but for swelling in the brain, that could be very well with that spinal cord injury. Mannitol. Mannitol will help decrease that edema. Then, in turn, what? Decreases that secondary injury, right? So then, better prognosis, per se, for the first 24 hours of any brain injury, or spinal cord injury for that matter, is touch and go. Could even be longer depending on the degree of the injury. Questions about that? Good? Okay. Sure.
Why are
More daredevilish. Yeah, those are ones that teach answers. In that age group, Melissa. Okay, good. Any other questions?